Well, welcome back, everybody. So yes, welcome back, everyone. So my name's Anna Wood. I work as a researcher within the partnership and also as an endocrinologist at Royal Darwin Hospital. And I'm very pleased to be chairing this next session. So first up, we have Dr. Jemima Weisbach, who is the project manager for the HESANDA NT node. She's also a postdoctoral researcher in the Child and Maternal Health Division here at Menzies. And she'll be talking about governance of Aboriginal and Torres Strait Islander data policy. Welcome, Jemima.
Thanks, Anna. Hello, everybody. Hope you're still awake after having some lunch. I'd like to acknowledge the traditional owners of the land, the Larrakia people whose land we meet upon today, and pay my respects to their elders present and emerging. And I'm just going to launch into it because I've only got 10 minutes. And click. We're clicking. No, yes, we are. Okay. So I'm going to speak today about the HESANDA project, which is the Health Studies Australian National Data Asset. So the reason they have put this project together, so this is a national infrastructure project funded federally through the ARDC, which is the Australian Research Data Commons. So the reason they have put this project together is to increase the benefits of the research data that has been produced by Australian clinical trial data creators. So, and why? What are the benefits of data sharing? Well, there's benefits for lots of different parties that are all involved in research. So the benefits for the funding body is that it increases the return on investment that they've made through the reuse of research data. And for the researchers to create the data, it's able to use their data to get extra recognition and visibility for the research and extend the life of the projects and meet their responsibilities to share data from publicly funded research projects and to expand their collaborative networks. And for health services that are involved in collecting research data, it improves their research health service practices, it raises their profiles and reputations, and it gives value adds to the data that's been collected through their service. And for researchers seeking data that's made available through data sharing, it inspires new research questions and provides opportunity to build richer and more extensive data sets. And it provides a systematic and clear mechanism to create collaborations and reduces cost and hopefully reduces duplication and saves time for new data discovery. So for participants, hopefully also it allows their contribution to be reused without having to get more personal time from them, and make the most out of the data that they provide and make sure that we're giving them value for their effort that they make in sharing their time and their samples with us and their personal information. So there are 9 HESANDA. HESANDA is a national project. There's 9 nodes across Australia that use or involve 72 different institutions, as is on the slide there. And Australia, Northern Australia is represented by Menzies in partnership with Charles Darwin University. So the HESANDA project, which is designed to promote the on-sharing of clinical trial data, was the nodes were funded to find custodians from within their institutions who are willing in principle to share their clinical trial data and set up processes within the nodes and institutions to support the data sharing. And this was by having processes and policies around how to set up your data set and your metadata, and how to store your data set and your support documents, such as your protocol, your primary publications and your data dictionary, so that if you get a data request, you can easily use these materials. We also had to do some technical things that are used to set up the data sharing process. So we had to set up a process for DOI minting research data sets. And we need to have policies, institutional policies and node policies about data sharing and how to go about that, and a template agreement so that some of those processes that traditionally take a long time are sped up a bit. And we also need the nodes to make sure the data set's prepared and the data about the metadata, the information about the data set, is prepared for upload so that it can be harvested. So Hesanda also funded some broader projects around data sharing. So they paid a consulting company to widely consult with clinical trial groups about how best to go about prospective consent for third-party data sharing in our consent form, so that we can build data sharing into our research at the onset, so that we have agreement from participants that they are comfortable with the data being used in certain contexts with certain governance principles overriding them. So, and the key thing that they did was they built an electronic platform to host the clinical data set metadata. So by metadata, I mean a description of the data set, and these descriptions are harvested electronically to a searchable catalogue, which is called Health Data Australia. That's the web address for Health Data Australia. It's open access. You can go and look at it. And this system has a built-in data access request portal. This is just what it looks like at the front. And this is a searchable catalogue. You can put in a keyword search and it will bring up the clinical trial data that's relevant to that keyword. And you can use the system to apply to use the data with a little, you have to put in information about who you are and what you want to use the data for, and it can be then transferred to the custodian through the system. There's a couple of key things to understand. I'm going a lot slower than I was when I practiced. That Health Data Australia only includes metadata, and the data stays with the custodian, and the custodian decides who can get to use the data. And there's a lot of processes that have been supported around this process. So you have to do all the usual things, ethics and governance and data sharing agreements. And last week, Menzies launched their Aboriginal Torres Strait Islander data governance policy. And this included a policy document, a checklist, and a case model study of a successful governance model, which is the Diabetes Across the Life Course Partnership Advisory Board. So thank you to Sian and Louise for supporting us to use their governance as an example. So the policy and the checklist are designed to use the principles of Indigenous data sovereignty and get them into practice in the way we generate and govern our data that's derived from our research. And the checklist is designed to prompt consideration of best practice throughout the life cycle of the project. So in this study example, so if, for example, one of the diabetes projects was to lend its data to its metadata to the platform, and they would get an application to use their data as part of a larger study about women who had diabetes in pregnancy across Australia, then the custodian would be notified and they could take the application to the advisory group so they could discuss the relative benefits for them to contributing to a larger study. And that's the key thing, is that always the governance processes that are existing aren't changed by using a platform like Hesanda to make the information about your data available. You still maintain control and you still get to choose who uses the data if you do choose to share it. So I'd like to thank you for listening to this very quick talk. If you want to go involved in providing data sets or using data, please reach out. There is some Hesanda brochures as well on the table at the front. So thank you and have a lovely day.
Thanks very much, Jemima. I'd now like to welcome Professor Louise Maple-Brown and Dr. Sean Taylor, who will both be talking about the NT Diabetes Summit Roadmap. So I'd like to just introduce Sean. So Sean Taylor is from the Murray Islands in the Torres Strait. He's the Deputy Director of Indigenous Leader and Engagement with Menzies and the Executive Director of Aboriginal Health and Diversity for NT Health. I'd like to welcome back Louise as well.
Do you know how to do this one? Oh, it's just this one. No, but that's not it.
Oh, sorry.
Thank you for that introduction. Before I begin, I'd just like to acknowledge the traditional landowners, the Larrakia people that were gathered here today, and I pay my respects to the elders past and present. Although I'm from Murray Island, we did remove terra nullius from the Australian doctrine, so it is very important for me to acknowledge that I live on Larrakia land, and I've been living in the lands of the Larrakia for the past 5 years when I left Thursday Island the years ago to come here. Progressing with the Anti-Diabetes Diabetes Summit. So Professor Louise Maple-Brown and Professor Christine Connors have been advocating around the epidemic, the diabetes epidemic within the Northern Territory for a very long time. And I was in a meeting one time and I picked it up and I said to Louise, I'm very keen to support the diabetes work that they've been doing. So we started to organise a summit in Alice Springs in November 2022. It was attended by 350 professionals and community members from across the Northern Territory that highlights the attendees, including and hearing about lived experience stories. And I think that was one of the highlights of the summit. Current research, which provided the evidence behind diabetes and the value of partnerships and the importance of a community-led initiative. The Diabetes Summit was in a partnership with the Northern Territory Government, which was NT Health, Menzies School of Health Research, Ben, who's here today, thank you Ben for attending, with the Commonwealth Health, the Northern Territory Primary Healthcare Network, and AMSANT, who were the partners that led the summit. A summit committed was the development of a roadmap to continue actions towards the social determinants of health to address diabetes rates in the Northern Territory. So in a lot of the presentations, there was research, a lot of stuff around with Renee, the social determinants of health and the lived experience. And it was such a wide and vast range of topics that was discussed. The roadmap, I'll hand this over to Louise.
So in the year since the summit, we've been working hard with all the partners who were involved in the summit, and particularly led by a team within the NT Health department, developed this roadmap that has now been endorsed by partners and is essentially ready to go. But if anyone has any final comments today, let us know. But it's very exciting to have the roadmap now ready to go, and you can't really see it very well there, so I'll break some of it down. But the first two columns are really about sort of the background behind the summit and the particular topics that we addressed and the strategies that informed it. And then this is the middle column from that roadmap document.
Hi, baby.
We good? So this shows the overarching actions and outcomes from the summit, and the themes really closely aligned and include the themes that were identified in the AMSANT Continuous Quality Improvement Diabetes Yarning Circle that had taken place before the summit, and they had produced an excellent document which very much the findings from the summit really closely aligned with that Yarning Circle document. So many of these words here are very similar, and that's because the themes were very similar. So key actions and outcomes there around meaningful community consultation and strong community voices, community decision-making and control, collaboration and collective impact, strong relationships working together, family and peer support models, support networks and group activities, local workforce and champions, investing in the Aboriginal workforce, promoting lived experience voices, telling health building stories, and then finally cultural safety and cultural respect and cultural safe spaces. And then the final two columns are around the next steps, really. So firstly, it's about informing two key documents, one being the NT Chronic Conditions Framework, which has essentially just been finalised recently, and that's for the next 7 years until 2030. And the key outcomes of the framework are written there around having a healthy diet, being more active, changing behaviour in relation to tobacco and alcohol, good social and emotional well-being, child and adolescent health, and then improving the identification and support as early as possible for people with chronic disease. So key outcomes all related to chronic conditions. And then we have the specific NT Diabetes Network work plan, which we're currently just developing for the next 3 years. And again, that priorities of that work plan are very much informed by the findings from the Diabetes Summit. So that's around supporting prevention initiatives with a focus on obesity prevention, support early intervention for management, and then focus on diabetes in pregnancy as well. And then the final column relates to a key aspect of the summit, which really was around cross-sector collaboration and cross-sector action. And there we've decided to focus on a key outcome being the prevalence of youth type 2 diabetes. And that is because that is an outcome of the NT Social Outcomes Framework. And it's a key measurable outcome where we do need action across government, because the social determinants of health are so critical there. And so bringing together cross government, so all the different government departments there to drive coordinated action on the social determinants of health to reduce the prevalence of youth onset type 2 diabetes. So that's really a key outcome related to this roadmap. So just finally, I wanted to mention another key piece of work the Diabetes Network has been doing here in the NT, led by NT Health, is this booklet around diabetes and the social determinants of health. And there's also a video that stars Sean. Sean might want to talk more about that. This book, I think, is outside on the table. I'm trying to see if Danielle Cooper's here. Danielle was here right at the back. Danielle is the person to thank for all these resources. Danielle's done an amazing amount of work in on this booklet, but also on the roadmap and in all the support for the NT Diabetes Network. So an enormous thank you, Danielle. And yeah, these booklets are outside and are also available online, as is the video with Sean. So I think that was it, but remind me, Danielle, was there something else I was supposed to say? Because I can't see the notes. Okay. Anything else you want to add, Sean?
No, but I do need to echo Louise with Danielle and the hard work that she's done, especially from the summit to the roadmap and also to the video and organising everything. So thank you for all your hard work.
Thank you very much, Sean and Louise, and I'll invite Renee up. Take some time. Yep, here we go. So this session is relatively short, but it's really important that we as the Diabetes Partnership can give you all a bit of an update and a snapshot of some of our more recent research findings and research activities. So it's not a comprehensive overview of everything that's going on, but it's just some of the important work that we think is important to give a bit of feedback around at the moment. So the first thing I'm going to show you is a very short
clip that was pulled together, which really highlights I think the breadth of our work and our main goals and vision as a group. Oh, but before I do that, I want to say this is a slide with all of the different team members and researchers within the partnership, so directly working within our group. And of course, you don't hear from everybody here today in the symposium, but I do want to acknowledge that all of this work is really because of the efforts of a huge group of incredible people. So I just want to acknowledge and thank everybody for their hard work and contributions and dedication to this space over the years. Now I will show you the video. Which I hope will work. Yep.
Diabetes, my story, our journeys. We can read it together.
The Diabetes Across the Life Course Northern Australia Partnership is a collaboration of researchers, health service providers, policymakers and community members. Together, we are working to address the intergenerational epidemic of diabetes among Aboriginal and Torres Strait Islander people. Families and communities affected by diabetes and related chronic conditions are at the centre of all that we do. The partnership, based at Menzies School of Health Research in Darwin, was founded in 2011 and now has teams and collaborations across Northern Australia. For our research and translational efforts to be effective, appropriate and sustainable, we prioritise Aboriginal and Torres Strait Islander governance through the advisory group, community engagement and privileging the voices of people with lived experience. In all our projects, we integrate knowledge translation activities and opportunities for two-way learning, capacity building and training. Our research highlights the importance of a life course approach to preventing and managing diabetes, with a particular emphasis on the health of young people and women before, during and after pregnancy, as this impacts multiple generations.
Diabetes, my story, our journey, we can beat it together.
One of the major highlights from our group this year has been was the submission to the House of Representatives Standing Committee on Health, Aged Care and Sport inquiry into diabetes. So we looked at all of our research across the entire body of work for diabetes, the Diabetes Partnership, and we came up with three really key priorities that we put forward. The first was around the need for public and community awareness around diabetes. The second was the importance of the social determinants of health and cross-sectoral collaboration. And the third was enhancing access to higher quality care. That submission has been printed. There are copies out here if anybody needs them. They're also on our website, or we can share them with you if you want to make contact. So that's it from me for now. Over to the rest of the team to give some updates. Rapid fire.
Thanks, Renee. So we'll start by talking about a major component of the partnership, which is the Pandora study, which I guess comes under the banner of really trying to better understand the intergenerational burden of diabetes and complications and outcomes from diabetes. So the Pandora study was started and led by Louise and started really 12 years ago now. And I want to tell you a bit about what the Pandora study involves. And really the whole aim of the study is about trying to better understand the effects of diabetes in pregnancy, both for women, but also that intergenerational story. So between 2011 and 2017, women were recruited during pregnancy to be part of this cohort. And so this was across the territory, both in central and the top end, urban and remote, and included women with and without diabetes in pregnancy. So women with gestational diabetes, women who already had diabetes in pregnancy, and women without diabetes in pregnancy, and involves non-Indigenous and Aboriginal and Torres Strait Islander women. And really with that baseline group, we're really interested in looking at the outcomes or the birth outcomes. And then we did wave 1. So wave 1 was when the kids were aged between about 2 and 4. And we did across the territory, the research team did data collection. And those main outcomes were looking at, well, how many women now after gestational diabetes had developed type 2 diabetes, and for the kids looking at developmental and growth trajectories. And then now we're in wave 2, which is the wave that's currently underway. This one started in 2019, was quite hindered by COVID-19, but we're back on track and hoping to finish data collection next year. And then of course, now thinking about wave 3. So just to tell you where we're at with wave 2. So the research team is, as I said, going across the territory and really doing clinical assessments. So for the mums and the kids, doing things like anthropometric measurements, you know, waist, circumference and skin folds and weight, taking blood tests, doing lots of surveys. And the aims really for the women or the mums is around trying to better understand or document the type 2 diabetes incidence after gestational diabetes. And for women who have diabetes, trying to better understand those complications. And of course, importantly, risk factors that might be modifiable. And for the kids is looking at cardiometabolic risks, particularly for kids whose mums had diabetes in pregnancy. So far we've seen about 460 women and 466 children. So what's next? Next is we're going to be finishing off data collection for wave 2, which will be by the end of next year. And then of course, analysing some of the outcomes for both women and the children. We have a number of biological working groups, and this is really about trying to better understand, I mean, firstly, some of the epigenetic changes, what actually, if we can better understand this intergenerational diabetes and the effects that diabetes in pregnancy have on offspring. In terms of kidney disease, trying to understand if there's any early markers or better ways that we can predict chronic kidney disease. And then the autoantibody group is about better describing phenotypes or characteristics of diabetes. And then of course, thinking about wave 3. So wave 3, at the moment, we're really just thinking about, you know, for funding and thinking about making sure we're engaging with our partners. And I think this would be a really critical age because the kids now are between around 12 to 18. And unfortunately, this is going to when we will start seeing diabetes and insulin resistance in the kids. And I think a very important time to better understand. So that is all from me about Pandora. Oh, well in time. So I'll hand over to Matt.
I've got my timer again, it's all right. I'm going to get it to work, I just wasted my time just setting my timer. Anyway, Alison's doing timers, isn't she? Hi everyone, I'm Matt, we've met before. So I'm going to be talking about some of our projects that use big data or data linkage to understand the diabetes epidemic better. This is, as well as being a clinician, my area of research is mostly in epidemiology, less the face-to-face with people, more of the sitting behind a computer doing stats. And I'm going to talk about 3 projects. There are a number of other ones that are ongoing. We don't have any acronyms quite as good as Pandora. I don't know if that'll ever be beat, but the 3 projects that we're talking about will be iHint, Impact, which are 2 studies that I lead, and CRISP, which is led by Dr. Liz Barr, who's based in Melbourne, a core epidemiologist, senior epidemiologist in our team. So firstly with iHint, that stands for Intergenerational Health in the NT. This was originally set up by Professor Federica Bazzi, who's now over at UQ Posh in the University of Queensland. And this is a retrospective data linkage study that has just over 30 years worth of data from the perinatal data collection. So has records about every birth in the Northern Territory of that time frame. And what we've done is linked that to get to hospitalisation data for all the public hospitals in the NT, as well as to the government primary care information system, which covers more than 50 communities across the Northern Territory. So within that, we have information about more than 112,000 births with a bit of information from the mum during the pregnancy. And we can then look at longer term outcomes for both mum and baby over that long time frame. So the key aims have been to look at the trends over time in diabetes and pregnancy epidemiology, so the rates of diabetes and what the outcomes of the pregnancies have been. With my PhD work mostly focused on the long-term cardiometabolic health of the mothers, and the next phase of the work will be focusing on early life risk factors as predictors for adverse cardiometabolic outcomes in the offspring. So what have we found to date with IHINT? We've just kind of documented, I guess, which has been helpful for advocacy around the growing rates of diabetes, particularly pre-existing diabetes amongst Aboriginal women in the NT. We've also looked at risk of kidney disease following a pregnancy complicated by diabetes compared to women who didn't have diabetes in pregnancy. And the key findings there, I guess, that women with GDM, 1 in 10 of them within 12 years of follow-up had developed chronic kidney disease. And of the mums with pre-existing type 2 diabetes in pregnancy, 1 in 10 had already progressed to being on dialysis. So this really just reinforces the importance of the postpartum period in terms of optimising care, ongoing continuity of care, and risk modification for long-term health. Some data that we haven't yet published looked at cardiovascular disease risk. So that's looking at heart attacks, strokes, heart failure, hospitalisation following a pregnancy complicated by diabetes. You can see the green line there compared to the GDM. That's the women with type 2 diabetes compared to in the red women with GDM or women without diabetes in the blue. This is just amongst Aboriginal women, the high rates of cardiovascular disease. And we've also looked with the student Emily Burton over the trends in pregnancy outcomes over a longer period of time from 2002 to 2016 between women with diabetes or without diabetes in pregnancy. I've just given one snapshot there for preterm birth, but we've looked at many different outcomes. Unfortunately showing that largely for women with pre-existing diabetes in pregnancy, there's been no improvement in pregnancy complications over that time frame, despite the 10-fold increase in prevalence. So the IMPACT study, this is a new one. It's called Improving Evidence Around Contemporary Therapies for Diabetes in the NT. A bit of a mouthful. Essentially, this is pulling together similar data sets. So we'll be looking at data from hospital episodes, primary care data from both government and some Aboriginal community controlled services, linking that also to the mortality index that the government keeps in terms of the date that people passed away, but also the cause of their death. And pulling all these administrative data sets together, we can really create quite a lot of statistical power to look at outcomes for the whole population in a de-identified way. So the main aims of this will be to kind of document for Aboriginal people in the NT what the incidence and risk of complications of diabetes is. So we're focusing just on about 8,500 people with type 2 diabetes, so that we can actually say to people, what is the absolute rate? We say you've got increased kidney disease, or what is the risk? At the moment, we struggle to actually provide those absolute numbers, and it'll be very useful in advocacy around how much this is costing the healthcare system and the importance of prevention and strengthening models of care for diabetes as well. Within this big data set, we'll also be looking at some safety and effectiveness analysis of some of the newer classes of diabetes medications. So things that have been proven in big international clinical trials to be effective at preventing diabetes complications, assessing in our own local population about are we seeing the same benefits, particularly with regard to prevention of progression of kidney disease and prevention of cardiovascular events. Finally, the CRISP study, which is led by Liz Barr, and I'm not directly involved in this, and Olivia Fox is the project coordinator who's here in the room. This is a project looking at cardiovascular risk in Indigenous people, and it's in its kind of second phase of work. The first phase really had some very important findings around validating existing cardiovascular risk scores that are widely used in primary care across Australia. This next phase is again looking at how do we best predict future cardiovascular events in Aboriginal and Torres Strait Islander people, and it pulls data from 5 historical cohorts. So unlike my other studies, which are looking at kind of government data sets, this has actually got very granular, detailed information from study participants from older cohorts from the 90s and early 2000s, but then linking those individual participants' study information from those detailed studies with healthcare records and mortality data, so that we can look at those longer term follow-up, because a lot of these complications take a long time to develop. So it's a very powerful data set that Liz has created in a huge collaboration. The study cohort involves approximately 5,000 Aboriginal and Torres Strait Islander adults. And the key aims there are looking at, are there different markers that we can include in risk scores to strengthen accuracy of cardiovascular risk prediction? particularly looking at improving cardiovascular risk prediction in younger people and in women. Most of the ones that we use in clinical practice are based on scores that were developed in the US amongst middle-aged white men in the 70s, and so they're not really that accurate in our own clinical context here. Particularly also want to look at identifying predictors for recurrent cardiovascular events and look at developing new and improved cardiovascular risk algorithms. So the point of having these algorithms is that in clinical care, you can look at what is someone's actual chance of having a cardiovascular event, and that will help determine clinical decisions about whether you use preventative medications or enroll in certain preventative programs. So this is an ongoing program of work. It's a huge amount of effort in terms of the data governance, you can imagine, across multiple jurisdictions and studies and communities to have appropriate community consultation and applications for approval for accessing the data for the cohorts. Then there's a period of analysis, and then within the project there's a real focus on ensuring that this is communicated to the right stakeholders and translated into clinical practice. And I know Liz in particular does a lot of work on national committees and things around cardiovascular risk assessment. All right, that's it for me. Thank you.
I think next we have, welcome back. Oh, sorry, not Diana, it's Renee next. All right.
So I just wanted to give a really brief update on one of our child obesity and diabetes prevention programs in Central Australia. So essentially this project was developed to address the identified need around the emerging rates of youth onset diabetes and obesity. It was also in response to requests from community and clinicians across the Northern Territory, specifically our advisory group and the Northern Territory Youth Diabetes Working Group, as well as the NT Diabetes Network, of the network. So essentially what this program set out to do was develop a culturally appropriate and family-focused diabetes prevention program. We aim to target Aboriginal children between the ages of 6 to 11 and their families. And we undertook some work starting in 2018 to adapt an existing program, so the Tribal Turning Point, which is a First Nations or a community youth diabetes prevention program, which was developed and trialled in among North American First Nations children and youth and families. So we spent 2 years adapting the Tribal Turning Point program to suit the context of Central Australia. So we worked with communities to find out whether or not a program like this was of relevance. If so, you know, what did they like? What adaptations may need to occur for it to be relevant and appropriate to the Central Australian context. So during that consultation phase, there were a number of key findings. These included community really indicated that there was a strong need for a program of this nature, but it needed to be owned by the community and it needed to be led and facilitated by local people in the communities in which it was being implemented. It also needs to be flexible and meet the needs of community priorities. And it also needs to acknowledge the various environmental and social contexts of various communities that are receiving the program. On top of all of this, there was a strong voice to say that implementation of this program needs to be evaluated. We need to know if it works, why, and how. And so the program was born, the adapted Tribal Turning Point program. The Munamata Atwea Arika, which is Aranda for Good Food for All the Family, was a program that has now been refined and implementation is about to commence in Central Australia. It's a 12-month intervention program, which we're running in partnership with Aboriginal the Congress in Alice Springs. The adapted program will be delivered to Aboriginal children and their caregivers in an active group setting. It's a 10-part program, so we'll be running it over 10 weeks, and it involves motivational interviewing as well as booster sessions over a 12-month period. We anticipate that will be running across 3 regions with 2 communities in each, so that would be 6 communities, with a 6-month intensive program, a part of the program followed up by the 6 months of maintenance, so that's the booster sessions and the motivational interviewing. And the control communities will commence their participation in the program 12 months after the intervention group have commenced. So the specific aims of the program or the trial is to assess the clinical effectiveness of the program among children aged 6 to 11, specifically in remote and urban communities of the Northern Territory. In comparison to the control group, we're wanting to find out whether or not it leads to a healthier BMI-Z score at 12 months, whether it leads to a lower BMI-Z score at 12 months, and whether it leads to lower reported sugar sweetened beverage consumption at 12 months. Importantly as well, we will be evaluating the implementation of this program using a mixed method process evaluation. This part's really important, as I mentioned, because it will give us the information we need to work out or understand what factors are really critical to potentially scaling up this project in the future. So what are all of the contextual factors and influencing adoption, how appropriate it is, and what we need to be looking out for in terms of delivery of content across the different communities in which it's being implemented. That's it. Oh, actually, sorry, I should just say it shouldn't really have been me speaking, but the team in Alice Springs are obviously online. So thank you for.
Now I'd like to welcome back Dr. Diana Mackay.
Thanks, Anna. I know you've heard quite a bit from me already earlier. So I won't be reiterating everything that we spoke about earlier in terms of the co-design project, but there's other work within the Diabetes in Pregnancy program to just mention as well. So some of you online and here in the room will have contributed to the partnership's previous study, which was improving systems of care and services for women with diabetes in pregnancy across the NT and in Far North Queensland. And this study had various components highlighted here on the slide, including establishing the use of the Diabetes in Pregnancy Clinical Register, embedding recalls and reminders in primary care and hospital electronic health records, providing clinician education, establishing various stakeholder engagement groups, including the Aboriginal and Torres Strait Islander Advisory Group, and making sure that guidelines and procedures were updated and promoted through clinical champions. So we've been working on the evaluation of this study, and this slide shows data from primary care in the Northern Territory, and really promisingly, there have been some improvements to care for women with diabetes in pregnancy following the implementation period of this study. So on the left, the green bars show whether women had any form of diabetes checks in the 6 months after their pregnancy, and that did improve. Also on the right-hand side, there was an increased uptake in contraception, which is really great to see. In addition to those postpartum results, the evaluation also found improvements in screening for diabetes in pregnancy, particularly in early pregnancy. And we also did surveys and interviews, which showed that there were improvements in health professional knowledge and confidence. However, despite those improvements, what our evaluation also found, and this data is from the clinical register, is that we haven't seen improvements in birth outcomes for Aboriginal and Torres Strait Islander women. This particular slide shows the rates for neonatal hypoglycemia, or babies having low blood sugar in the early period after birth, which is one of the complications of being exposed to the mother's high blood sugar levels. On the left-hand side are the results for non-Indigenous women, and on the right is for Aboriginal and Torres Strait Islander women. And you can see on the left that there was a decrease for non-Indigenous women, or the babies born to non-Indigenous women, I should say, whereas no improvement for those born to Aboriginal mothers. And this is just one outcome, but we saw similar findings across several outcomes, really underscoring, I guess, what we've spoken about today, that there are broader things in terms of those social determinants of health that need to change to actually have an impact on outcomes. While that particular study has concluded, the diabetes and pregnancy clinical registers are still operating and currently under the leadership of Matt. They are in a process of transitioning from manual data collection and data entry to an automated process of data extraction. But I guess you can probably understand this is quite a long process and complex process to go through, which may be why some of you who heard a bit about the clinical register in the past may not have received so much in terms of updates most recently. We are also in the process of reinvigorating our clinical reference group in the Northern Territory and strengthening further the advisory group in Far North Queensland, and are always open to hear from people who would like to be involved in those groups, so you can contact us on the emails there. Just one important thing to mention about the clinical registers, they do operate on an opt-out consent model, meaning that women will be automatically enrolled. If they have diabetes in pregnancy, they can opt out using a form available at our website. And just briefly, as you're aware, we have our co-design study, which is underway again in Top End, Central Australia and Far North Queensland. We did already share with you the early findings from our NT sites in terms of those priorities. And the next steps for this study, which we're working on currently, our team in Central Australia are planning for implementation from the beginning of 2024. In Top End, we're just working with the community to really confirm and refine those priorities that have been identified. And in Far North Queensland, we're really still getting started with recruiting participants for the first phase of the study. Thank you.
Thanks, Diana, and welcome back as well, Dr. Angela Titmus.
Hi, so I'm talking about the Youth Type 2 Diabetes Project, which is co-designing, has a few components. So there's an audit of prevalence, which people may have heard about. We initially did the audit using 2017 data, and it was published in 2021. And then there was also formative work that was really about understanding the needs and experiences of young people and communities and family members affected by type 2 diabetes. And the current work is about co-designing models of care, and I'll talk a bit about that now. So firstly, looking at the prevalence, this data has kind of already been mentioned today, but using the audit data, which included all Aboriginal community controlled health services across Northern Australia, as well as all NT health data, and most of remote sites in the Kimberley, and then also Queensland health data, showed that Central Australia's prevalence was unfortunately the highest reported prevalence of youth onset type 2 diabetes within the last 25 years in the world. And just kind of showing our regions and just emphasising, I suppose, with thanks to all the community controlled health organisations that really have prioritised this as an issue and provided their data. And the other important thing, so like the wrong presentation's been here anyway, is the glycemia. So that the median HbA1c was 9.7%, and only 15% of young people were in target, which were defined as an HbA1c of less than 6.5%. So there's a slide missing, but I just wanted to talk a bit about the formative study, and which is really led by Emma Weaver in Central Australia, but it included interviews of 27 young people across the Northern Territory. And there were some really key findings that came out of that have driven the rest of the project. And it showed the key themes were firstly the complex emotions that occurred at diagnosis of fear, shame, that led to complex behaviours, a kind of avoidance, denial and resentment of health services and being engaged in health services. There's a normalisation shame paradox, so that diabetes is so prevalent in families, but that actually leads to, despite that high prevalence, a lot of shame and a lot of stigma, and also apathy or feeling that young people can't change their trajectory. And then also that study also looked at what would be the resilience, or what are the strength base, and there's opportunities to improve the understanding of young people with type 2 diabetes, and in holistic care, really working about how we can engage them in a really supportive environment that addresses all of their needs. And so that's led then to the phase 2, which is the co-design project. It was funded by the Commonwealth Department of Health from 2019 to 2023. And it's a few aims. Firstly, building awareness and support networks amongst youth and communities and amongst health systems and health professionals, improving diabetes knowledge, enhancing and developing the relevant support systems, and positively influencing self-rated quality of life, including emotional wellbeing outcomes. This has actually been, the data here has actually increased since when it's on this slide, but there's 28 lived experience narrative kind of educational videos. We did a webinar series last year, and it was a 10-part series, and then this year there was a 3-part case study series looking at youth onset type 2 diabetes. There's participants that have been recruited across Northern Australia of young people, but also family and community members to share their insights, and health professionals. Lots of working groups across the region, as well as co-design workshops with families, health professionals, and with young people. And so I suppose the key learnings that we've seen from this co-design project is that appropriate support, and we've already heard this a lot today, but that it requires holistic care, it requires meeting people where they're at, having time, being flexible, and often our health systems are not designed in that way, or people feel pressured. It's really important to identify someone who can build a continuity of care and rapport with a young person, and building meaningful relationships, and looking beyond the health system to schools, to youth workers, to other sectors. Increasing community awareness of type 2 diabetes in a similar way as community awareness is built about other conditions, and considering wellbeing in a very broad concept. And so the recommendations have been to raise awareness and understandings, to increase the knowledge and the capacity of the workforce, increasing support, particularly after a new diagnosis, as we know that's a really high risk period, and developing peer support and peer-led kind of diabetes education models. And so we have some funded work, which is very exciting. It's just kind of been announced very recently. And so we have 2 projects continuing. One is led by Renee, a multi-pronged approach to enhance youth type 2 diabetes management. And it's a 4 years of funding, and it's across 3 regions: the Big Rivers region, the NT, Central Australia and the NT, and then the far north Queensland. And it has 3 components. One is to evaluate our screening algorithm that we're using and thinking about universal screening for young people. Secondly, to improve culturally appropriate care delivery, and particularly how we support mental health and wellbeing, and build the capacity of health professionals in doing that to support young people. And thirdly, looking at that period after a new diagnosis, and how we can improve clinical support to primary healthcare services, and also looking at how we can enhance support for young people, such as through the use of sensors in terms of education and titration of medication. And then the second funded project is called Doing It Together, and it's focused on the Big Rivers region in partnership with Worley, Wirlinjang, Catherine West Health Board and NT Health in Borroloola. And we're looking at peer support and peer-led education for First Nations youth with type 2 diabetes. And I should say that both of these projects really come about because of the findings from the work so far, and the feedback that's from communities, from health services, from young people about what they need. And particularly looking at peer support, it's been happening for a while in Worley, Wirlinjang, and leading on from that, what's the next stage for those young people? And they've kind of identified it as being peer-led education. So it's been driven by community needs and what people saw as the next steps. And that's it.
Fantastic. Thank you, Angela. We do have a few minutes for any questions. We'd love any questions or comments around any of this research, or any feedback for the partnership. Be great. Is there anything online? All right. So we might as well run early then if there's no questions, which would be nice. And so I'd like to introduce our next speaker, who is Cecilia Gore, and welcome her to the stage. So Cecilia Gore is Acting Deputy Chief Executive NT Health and the Acting Deputy Chief Executive Sector and System Leadership for NT Health, overseeing the mental health, alcohol and other drugs and suicide prevention sectors. She has vast experience in healthcare leadership and a strong commitment to improving the systems which deliver mental health, addiction services and suicide prevention outcomes. Thank you. Yeah.
While they're playing with the tech, I will start by acknowledging the Larrakia custodians of the land on which I'm standing today and pay my respects to elders past and present. I've been fortunate enough to live here in Garrumulas for nearly 10 years. I was born in Brisbane and I've worked in New South Wales and Queensland, and then came up to Darwin, and this is very much my home and it's where I plan to be for a long time. When I first came here, I worked at Menzies for a very short period of time on the Life Skills program, which was being run through the through Gary Robinson Centre. And it was working with middle school students in life skills around trying to prevent suicide longer term. And so when Renee, that's where we met Renee for the first time. Since then, I've traversed a range of different roles, but for the last 3 years in particular, we've been working on how do we bring people top of scope across our remote centres to address what we know are really significant challenges with social and emotional wellbeing and mental health for young people. And the connection with this work is the diabetes roadmap actions. You could just delete the word diabetes and put mental health in. And for many, many years, the National Mental Health Strategy talked about, we know that people who have chronic mental health usually also have chronic physical illness, and vice versa. And increasingly, for me, what that means is we actually just need to do social determinants. There's nothing that's particularly diabetic that leads to mental illness and vice versa, but there is absolutely, particularly in the Territory, really strong connections between where people are living and how they're living and the conditions in which they're living, which create vulnerability and risk. And so I think there's an opportunity for our different areas of expertise and interest to work much more closely together to get proper traction on these issues. One of the things that I think is really important, this is actually the social and emotional wellbeing social and emotional wellbeing framework that was developed in about 2014 by a range of Aboriginal psychologists. And why I put it up again is it's not the way that we think about mental health and wellbeing. It's actually not a diagnostic tool. And so to decolonise our responses, we need to look at the words in here, which are all about connection. So that it's connecting to culture, it's connecting to family, it's connecting to things that give people lives of joy, hope and purpose. And when we talk about what we're doing, and that's what's exciting about the peer-led stuff, is that people are crying out for things which make them feel like they belong, that they're part of something and that they're valued and that they're worthy. And those are the conditions that let people want to live lives of joy, hope and purpose, both in the area I mostly work in, which is mental health, but also in any of the chronic conditions work, particularly when we're talking about young people. One of the things that we're trying to do is take a picture here, and you would use exactly the same language in talking about some of the diabetes initiatives. We need to broaden our reach, we need to increase access in remote so people aren't having to travel in for special care. But most importantly, we actually need to think about what it means to deliver culturally appropriate care in the context of these dreadful social determinants that we are continuing to fail to actually meaningfully get traction on. And I think, while I think it's important that we listen to people talk to us about programs and short-term interventions and psychoeducation models, we are going to keep failing, as the slide showed, if we cannot get our heads around how do we change the resource invested into housing, into education, and not diabetes education, but keeping kids in school for as long as possible. Not mental health education, but giving them safe houses. So I think that there's a real challenge that we have to, in your role as leading researchers, address. In terms of partnerships, there's two things that happened for me, and my portfolio was mental health and AOD. And if you think about what happens, what we know works in leading people down lives of better choices and healthier outcomes, most of the universal stuff is genuinely universal. The same things that enable kids to have good physical health are the same things that let them have good mental health, until you get to the really severe acute complex end where we have psychiatrists and addiction medicine specialists and endocrinologists. So we actually, for me, are doing lots of work on rethinking what a specialist service is in the context of the care, and how do we bring everybody else in so that everybody sees this as part of their story. You don't need to be a specialist mental health worker to contribute to somebody's wellbeing. You don't need to be a specialist diabetes educator to contribute to young people's sense of worth and self and what they're doing in their choices. And the simplest way that we've started to talk about that is to ask people to be top of scope. So if they are working in a school, so at the top of the thing, what are the things that they can do in their core business that makes it more likely that young people will have a better outcomes from their engagement with them? And so the classic one in the mental health and wellbeing one is kids get great benefit if they think their teachers like them. Teachers don't need special mental health training. They just need to give positive regard. And so starting to talk through what the different levels of that are, so that people who are, young people have touch points with, understand the role they play in the system and how they can support the other parts of the system. And in the red, the very special workers who've got really tight knowledge, which is rare and needs to be applied to those who need it most, they also have a role to support the others, so that people don't feel like they have to say, this is not my problem. I don't know what to do, because I do know who to call because they're next to me in this clinic or they're around the corner. So that settings-based work and the Big Rivers stuff where you've actually got people all in a geographical region coming together to talk about this stuff, the conversation can be anything. Whatever the risk or the vulnerability is, the strategies are going to be really similar, and that's where I think the partnerships are possible between the various different sectors in health. And that's enough. Thanks.
So I now like to call together the panel members. Cecilia, thank you, is the first panel member who's already been introduced. If the other panel members would like to start walking down, we have Dr. Sean Taylor, who's Deputy Director, Indigenous Leadership and Engagement here at Menzies School of Health Research and Executive Director of Aboriginal Health and Diversity for NT Health. We have Ben Modalia, who's come all the way from Canberra. Thank you very much, Ben, who's the Assistant Secretary of the First Nations Health Division in the Department of Health and Aged Care. We have Nathan Garawara, who is an Aboriginal health practitioner at MeWatch Health Corporation. And we have Cheryl Sanderson, who's a credentialed diabetes educator, one of our few diabetes educators who identifies as an Aboriginal woman, which is wonderful, and who currently works with communities across West Arnhem Land and previously worked in Central Australia and Darwin and WA. Okay, thank you all, panel members, for joining us. I thought I would like to start by asking each panel member for their reflections of the day and learnings and thoughts on next steps. And I know that Ben's been doing some thinking about this, so I might start with Ben. Is that all right, Ben? you're first in line over there.
Stuck.
Oh, it doesn't quite reach. Is that all right?
I'll try and pull a few threads together from today's presentations. I do want to start though by acknowledging the Larrakia as the traditional owners of the land and pay my respects to elders past, present and emerging, and also extend that respect to any of my Aboriginal and Torres Strait Islander colleagues that are here in the room or online today as well. there was some really strong themes that came through in the presentations, and I also want to acknowledge all the presenters. I came up from Canberra last night. The flight was delayed. I don't think we got in till, I can't remember what time it was, close to midnight. I'm still in Canberra time, so I woke up at like 5 a.m, having gone to sleep at about 2 a.m. And I only just started to fall asleep at a couple of moments after I'd eaten food. And I have type 2 diabetes. And so I know that those are factors underpinning kind of how alert I am. And I say that because all the presentations were engaging. Some were really profoundly affecting, and I do want to talk a little bit about that in a second. But for me to stay awake the whole day without having the opportunity to talk is an amazing achievement, and hats off to all the presenters for that. I think there were some really strong things that came through, as I was about to say, some strong themes, and I just want to pick up a couple of them. The themes around racism, which were a constant theme throughout the day. There's a larger context here, which is post-referendum. And then there's, I thought was a really powerful presentation by you, Mary, around microaggressions, because it demonstrated how racism can emerge in polite conversation, in common sense scenarios, inverted commas. And we can all be the transgressors, because we are enculturated in a particular cultural, social, institutional context very often, where we carry these things through, and sometimes we reinforce them in our conversations with others simply because we haven't yet learned how to say, hang on, do you know what you're reinforcing when you do that? There were themes that fell out of that around overt racism, covert racism, individual racism, picked up some of the stuff around structural and systemic racism. And I just want to draw a link to what I thought was another really strong theme out of the day, which was the cultural, social, and structural determinants. And for me, that's why I'm really interested in particularly the structural and the social determinants as a bureaucrat, because that's where I have a sphere of influence, I think a stronger sphere of influence, and the opportunity, as Cecilia used that phrase, the opportunity to work more closely together to figure out how do we make sure that the various bits of expertise, knowledge, and power are being brought together in a way that generates change. Now, I sit on the Northern Territory Aboriginal Health Forum as the Commonwealth Department of Health representative there, which is a really valuable, I think, partnership forum. And one of the conversations that we've been having in that context is how do we get better traction on housing? As health agencies who are primarily around that table, how do we start to engage with other departments, be they in the Commonwealth or in the Northern Territory, especially in the space of housing? Because we know so much primordial prevention occurs there. And if we can get progress there, then we can see the health benefits flow through. And yet it's such a challenge, right? It is such a challenge to engage my Commonwealth colleagues. I suspect it's equally a challenge to engage Territory Families colleagues in some of those conversations. And I can only imagine how hard it is if you're not working in government to try and get that done. And so for me, that is actually a manifestation of structural and systemic racism, because what's happening is that there is a particular cultural lens that we're applying that says, here's the world, let's divide it into these themes. And then I'll operate in this theme and I only care about this theme. And the ability to work across that, to see things holistically in the same way. I always have my Aboriginal colleagues saying to me, think holistically, don't think body parts. The parallel there is for government as well. So all of that to actually just set up what I really want to say, which was the lived experience presentations for me were profoundly affecting today. And I want to acknowledge Ben, Nolisha and Neil for their courage, and also Sian, even though she wasn't one of the lived experience presenters, it came through so strongly right throughout the day. And as a bureaucrat in Canberra, my job is to shepherd ideas through to ministers to get them to agree to spend dollars on a given thing. And typically the argument starts off with Aboriginal and Torres Strait Islander people are disproportionately represented in, right? And it's a pretty cold statistic. And my staff will end up kind of being quite expert at telling that story. But the real thing that people need to grasp is, why does that matter? Like, why is that important? And when I am witness to those lived experience presentations, it drives home really strongly the why. And it's when you have I have an observed experience of the why, and my staff who are with me have an observed experience of the why. When they tell that story to government and to ministers, they might still use disproportionately represented, but they can tell more nuanced stories as part of that. So I just want to leave it there and hand over.
Thanks. Thank you, Ben.
So thanks, Ben. I agree 100% with what Ben has articulated. My research in the far north Queensland was around diabetes as well. So diabetes is very close to me. And I've seen many people in the Torres Strait, especially in the Torres Strait, who have passed away by poorly managed diabetes. And I mean poorly managed. I've seen people froth up in toxins because of going through renal disease and then dying very early. So the complications were quite severe in the Torres Strait, and it will happen in the Northern Territory on the rate where we are going. So that's why it's very close to me. However, in an executive role, it's around changing the system and hearing presentations throughout the day. How does the system change to allow and for the patient to move through the system? A lot of the research that I looked at was around health literacy. A bit like Ben was saying, the why. The patient said to me, Sean, we can read and interpret the medication. We know how to read the appointment. We know how to go to the doctor, but why are we going to see the doctor? Why are we taking these medications? Why are we doing this? So it comes down to communication. And a communication across all levels at a corporate, clinical and cultural lens for me. But the ongoing research, how do we keep the sustainability of research and translating that into practice, into any health services that we're working for? And I think that's been a big thing for me, is the translation of research and sustainability of research through the health services.
Yeah, I would say it's a big issue for remote communities, especially when it comes to complicated diseases such as diabetes. But the highlight for today for me was hearing the great stories and inspiration. Make me be inspired, and great stories, and there are good people out there just trying to make a change. And I won't go to the structural thing because I'm not in there. I'm basically in the grassroots level, so I won't get into that. So, but what would I admire is that story, and hearing that story today was great and very inspiring. That's what I'd say.
Cheryl Sanderson, credentialed diabetes educator working for Malala for the last 9 months. Before that, I did a little stint in Broome, and then before that, me on a few Aboriginal film sets as a nurse. But 20 years in Central Australia, so I'm proud to say that I'm a proud Central Arrernte woman whose mother was born under a tree in the bungalow there. And I've just come up to the top end just to follow my career as a diabetes educator, but I was 20 years at Congress, AMS. And thank you so much for inviting me on here. I feel like I don't belong on this panel, but I always do love coming to the symposium to network and find out stories from other people. I am on the ground. I'm at the forefront. I'm flying out practically every Monday, going to 5 West Arnhem communities on the ground, and I am experiencing, I'm a diabetes educator, but if I've got someone that comes in, I'm not always just diabetes, it's just you know, hi, how are you, going through the F's, fishing, family, food, what do you do for fun? Because I need to build a rapport. But if you've got a nurse bringing someone to me, it does break my heart sometimes when they're like, oh, we've got this man with diabetes here for you. He's non-compliant, hasn't been taking his medications. And just saying it in front of people is just like, it really, I don't know what to say sometimes because I am on the ground, but it's nice to share it with everyone and just say, please reflect on language, because language matters. And sometimes you can say something, but you just need to build up that person that is coming into the consult with you. I do like to go out to the community too and visit the art centres and that sort of thing, just to go. And so Maningrida is obviously the first place that I went to, and go to the art centre and just go, hi, I'm the new diabetes nurse. And it's like, ooh, who's this lady? You got a story about diabetes for me that you want to share? It's like, no, you tell the story. I'm like, no, you tell the story. And anyone with diabetes, and there'd be 5 ladies there with one lady behind going. So it takes time. It's been 8 months. I go out, but wherever I go, it's sort of, especially with young people's, my passion is the new generation, young people or preconception, or young ladies who are thinking about getting pregnant or want to get pregnant. But it's amazing how I'll go to, like when I went to Broome and I was in Derby, there's this young person that was from Central Australia. What are you doing here? And then it was Menzies who I could contact and say, hey, I've got this young person here, and try and link them back into services. And yeah, so I've just tried to, throughout my career really, I have linked in with Menzies because it was the young people that were trying to, we started that first program in Alice Springs with Urara School and the YMCA, and trying to get group stuff. But group work is really, really hard, and I'm trying to think about it in community. There's cultural, there's business, there's poison cousins, there's poison relationships, and there's groups that you have to think about. And I think group work does work, but on the ground there's just so many challenges. So yeah, I just arrived from Gumbalunya last night, and it's tiring too, but God, I love it. I have the best job. Right.
Thank you. I might ask you to pass the mic back to Nathan. I have a question for Nathan. Nathan, I know we've had a bit of a focus today on the strengths and resilience aspect, and I know that's a particular area of yours as well. From your perspective, what works best to support community members to stay well, socially, emotionally, as well as physically?
Yeah, the best thing about me going out into the communities is, how do I look at it from my perspective in the community, is I go there with my ears wide open. That's the key, is you go and listen to each individual's stories and circumstances. That gives you a clear picture what you're dealing with. Because I want to give them the platform, give them the space and opportunity to see things from within themselves, not what I see that I need to tell them. So you are listening to them talking to build up something that they don't share with other people. I call that kappo, which is water. You let the water build up because they have you don't see. We all don't see. We all have uniqueness within ourselves. And the key to that change is from within themselves. They can only drive forward from within. It's like my brother was saying there. I like that story. It's very inspiring. That's the kind of stories we want to see. Is someone taking, and young people mainly, to change from themselves. We can throw all we can programs, and I got nothing against programs. They're great initiatives and programs, but we want to see them drive it. They have to be in the driver's seat. Change comes in from within themselves. They have to feel they are motivated and determined to change. If you want to see that happen, you have to give them the time and space and platform and let them grow. And from emotional sides and physical and spiritual is what we heard all here. It's in a spiritual sense that's who you are. That's what I always tell other young men in Galwinco, where I'm from, Elkowara, but I talk about the sense of belonging. They have to uncover who they are. That's how they are going around to the different places, because they don't have the sense of belonging. Their identity, their connection, their culture is the key to their growth. They need to embrace that and understand that health, they need to understand their identity. Reason why I say identity is it's a health-wise. Their identity is who they are. And they have to build that relationship with themselves. It's not other people coming and building it for you. They have to build it from within. And their connection is the key, and spirituality that connects them back to that place that I said earlier, sense of belonging. That culture is putting them into that place where they belong, where they can always say they belong. I am from here and I'm a proud this person. I'm a language, this is my language, this is my country. That's putting him into that place where he feels proud to be who he is or who she is. That's what I see in a spiritual sense. Physical and emotional is you have to be up, working, learning, earning, getting knowledge, learning from others, connecting. That's the key to building that self-reliance, that you get to that space where you can be the key to change and change maker. And that's what I support mostly young people, is to know who they are, where they're from, embrace it, and be proud who they are. They can always say who they are, where they're from, for the rest of their life. And our culture plays a huge role in spirituality. that's going back inside to what this symposium is, mental health. You're putting culture here that heals your mind and your body. Culture works from inside out, not in. More that they learn about themselves, and they're going within themselves. They are unlocking their potentials so they can look better outwardly and know what things they need to do, how they need to do it, who they need to connect with. And that goes back to their services, programs. See, big programs there. They just need to connect with the right people, know the right people, talk to the right people. But the main thing is, I think, is they have to be driving their life, not other people. And I believe in that. That's what I truly believe is change comes from within. You have to take ownership and build that ownership from inside out. Your body is your relationship with your body. More that you work with, you communicate with your body, health-wise, better health, nutrition, everything, the more that you feel that you need to do, that you can help others, like my brother was saying, and others here. It's about that driving force behind what needs to be changed from young people's perspective is knowing who they are, strong, capable people with uniqueness, which is their culture. That's their bedrock, that's their foundation to stand on.
Thank you. Beautifully spoken. Thank you, Nathan. Do we have questions for the panel from the audience? We have some very senior people here from NT Health and Canberra who are happy to answer questions. Are there questions online or in the audience? I'm sure we can otherwise keep going with other topics up here. Cecilia, you talked a bit about the commonalities and trying to break down, thinking about breaking down, being less siloed between different sort of conditions, diseases, and social determinants of health crosscuts across it all. How can we improve that?
How can we improve our social change? I think we've got to stop using committees as our source of action. Committees are good at admiring problems, they're not good at solving them. And so I think that really there is opportunity, and I think Ben's points from earlier around this is not a new agenda, and it does take people like Ben and others in those places to challenge their colleagues to change our investment frameworks. And I think the biggest opportunity we have at the moment is the Closing the Gap priority reforms, which talk about both partnership, but it also talks about actually transitioning services across to community controlled orgs throughout the country, and particularly in the Northern Territory. And what's becoming uncovered as that's happening is that there is insufficient investment to transfer the programs. And so the complacency that government has had about remote's just too hard is being really challenged right now in this moment. We can't achieve our commitments under Closing the Gap to transition to community control if we don't find further investment. So you, in all of the work that you're all doing, have an opportunity to keep hammering that home. And it's not a vague theoretical social determinants. It's how are we going to improve our community housing? How are we going to get people in this community running running the housing? And I think that opportunity, everybody swings in behind. We know that it improves school attendance. We know that it improves people's school attainment. It improves people's mental health and well-being. It improves people's sense of safety. It improves all of the chronic conditions. And it needs to be framed as someone is going to be accountable to make that happen, because no committee's really ever achieved much in the history of the thing. I think there are signs of strength and real hope in progress. I think particularly in Central Australia, we're seeing some very strong leadership from Aranda and Walpuri, people in roles who are calling government to account. And I think we just need to get behind them and say, yep, we agree. In terms of my work, we have lots of attention to where are we currently investing and how can we change that? How can we move that money into different places in different ways? Part of it is, you'll see it sometimes in the media, not investing in more hospital beds, but investing in community residential supports. Joining up with other housing providers like Kalano and Catherine to go, let's use their infrastructure as the way we improve step up, step down facilities for people who've got mental health concerns. So we don't fly them to Darwin to the hospital, we actually try and work with them in community, and we employ local people from Worley to work with them at that real local, culturally appropriate way. So these little small things that you do, but with a really strong intent, which is we're trying to achieve the justice targets of closing the gap. And we have to own that, and we have to do it every single day.
Thank you. Ben, did you want to add anything to that?
I'll probably pick up the other one of the other priority reforms under the National Agreement on Closing the Gap. So Cecilia paid particular attention to, I think, 1 and 2, but 3, which is priority reform 3, which is about government transforming the way it does its business. So if you think about this institution of government, which has politicians, and as I'll make an apolitical statement of all politicians, they're in the business of power, right? Power and influence. And without wishing to cast any aspersions on them, I think most of them get into that business because they want to see the nation built in a particular way. But it is wielding power, and the bureaucracy is engaged in the business of wielding power as well. It's a different way of giving effect to power. But the National Agreement on Closing the Gap and Priority Reform 3 asks the bureaucracy to rethink how it wields that power. And it ties back to 1 especially, Priority Reform 1 especially. How do you start as a bureaucrat to give up your power and share it through shared decision-making arrangements, through partnership arrangements? That's a big challenge, I think, for officials, because they've worked their whole way through a career with each step in promotion about trying to have more and more influence. And power can be a good thing. I'm not talking about force over others. It can be the power to work together to achieve something, but they don't always come together in that way. Sometimes it is about the application of force in some sort of way. And so I see a lot of practice amongst officials from other Commonwealth departments who I don't think have grasped at all what Priority Reform 3 means or what Priority Reform 1 means. And so their approach in any kind of engagement is, I have the answer. And I think anybody that goes into any of the complex issues that just affect the whole range of social, economic, policy responsibilities that government has a capacity to influence, but thinks that they can do it alone, is missing the point. And so I think the more quickly the bureaucracy can grasp the idea of devolving power, working in partnership, recognising that they don't have all the answers and that they have to, as Nathan started off so eloquently in what he said, go in there and listen, then we can make progress. But if we don't do that, if we're just there to prosecute an agenda, we won't hear others and we won't find joined up solutions.
Thank you. Sean, I might turn to you. You've got the mic. Maybe with your Menzies research hat on, where does that, thinking of the closing the gap targets, and how does sort of the research implementation translation angle come in there? How can we improve that in terms of social determinants of health and across the closing the gap targets?
Actually, it's quite timely because I left the meeting to go to an NHMRC meet, and we were talking about how reflecting the target falls for research aligning to closing the gap, and especially for Aboriginal and Torres Strait Islander research, and aligning most of that. So it was quite timely that we had that discussion this morning. But in Menzies, Menzies does a lot of good work across the board. We probably need to start aligning that again back to the closing the gap initiatives, and when we're sending up our reports, so that we are articulating the good work that Menzies is doing to the Commonwealth, so the Commonwealth does know that there are great works, because you don't see it reflected in the reports. And I've seen that over a number of years now, that research is not included most times. It is those who report on it, but not all research. And I think Menzies can strengthen that alignment.
Thank you. And maybe back to Cheryl. Cheryl, you're on the ground out in community, in an Aboriginal community or several Aboriginal community controlled health services. You've got a couple of senior government people here in the room. What do communities need from government, and how do communities' voices be heard, and priorities align with communities and government's agendas?
Gosh, that's
Sorry,
a big question. And I mean, I don't represent absolutely everyone, but from some of the vibes that I get is, yeah, I'd love to see, and a lot of other people would love to see more Aboriginal people employed in the health space, or just in generally having some sort of support. Aboriginal health practitioners, more Aboriginal nurses, giving pathways, or people that are living on community, because look, they would be the brokers within community, cultural brokers, have a better understanding, just knowledge about cultural sort of stuff and everything. So yeah, definitely yes to more Aboriginal health practitioners. And over 20 years time of being Central Australia and remote communities there, I've just seen Aboriginal health practitioners dropped off or pushed aside, and say, they'd been running the clinic by themselves, and yeah, more staff have come in, but it's generally been nurses, maybe doctors coming in, and they get pushed aside and made tokens, and then they've sort of just put under too much pressure to either be transport drivers or go out and grab people and bring them in, and then go off and sit on committees and all that sort of thing too. And yeah, we just lose them. And we've lost them, and it's just so much knowledge and power that can come. And I meet people nowadays that in consults that say, "Hey, I used to be an Aboriginal health practitioner. What happened? I don't know. They're still, like I say to them, like, you still got that in your heart. You still got like being a healer and health practitioner in your heart. So never let that go." But they sort of don't have roles in the healthcare system anymore. Some of them do. There are some people that have got positions, say, with ANFPP. So that's still a really important role. So yeah, I would say trying to support. I'm not sure how. More Aboriginal health practitioners, more Aboriginal nurses. It's happening. I know it's happening. There's more Aboriginal doctors coming through, but it's kind of slow. And then when there are positions that are made within the hospital system, so I know AHPs that were put in, say, for example, Alice Springs Hospital, this was years ago, they were sort of looked at because they were special considerations and put into those positions too, or put into those roles, and it's like, oh no, you can't do the bloods, or you can't just go over there and talk a bit of language and make a cup of tea. So then they didn't have a valued role in there, although they'll put in those positions, oh, we know how she got the job. So being just put aside and not valued or not felt like they had a purpose. So having a purpose is really, really important. So yeah, it's a struggle. Once Aboriginal people do get into the roles, then it's a struggle again. So I'm not sure. Yeah, we do need to have, and obviously diabetes as coming from a nurse, diabetes educators too, and supporting nurses to go into diabetes education, because just getting that knowledge, because it does help understanding. Yeah, there's a lot of things to consider. So shout out to my daughter too, in Alice Springs, who is just about finished her 2-year graduate nurse program with Congress and the hospital, and she's like gunning to become a diabetes educator too. I want to be like my mum. So I do support any young people, and every year I'm mentoring someone as a diabetes educator too. So I commit myself to always being some sort of mentor. And yeah, I can talk until the cows come home, but it is Friday afternoon. So I've met so many people up here who have like supported me and that sort of thing. But in general, I don't know, to the government and to policies and that sort of stuff, I am on the ground. There's other people that are on the ground. I'd like to see more Aboriginal staff or supporting local Aboriginal communities into roles that are suitable and that are not just 9 to 5. It might be. And I would say that Maningrida and Malala are doing a great job. They're employing Aboriginal people and being flexible and all those sort of things. So, yeah.
Thank you. Questions in the room? Everyone's got Friday afternoon-itis. Oh yeah, here we go. Excellent.
I recently went to a community and they had the yarning book session.
We've just got a mic coming for you so people online can hear. Thank you.
Sorry. I went to a community recently and a yarning group was happening there. So all the clinicians, the organisers, the allied health providers, the HPs were all there, but there was no client. I understand the community was trying, they had the source the funding and, but how can people together make it more efficient in service? I mean, the government definitely has recognized the need to provide all these group sessions to raise the awareness and everything, but on the ground, why is it so hard to get people to use these services?
Not sure if Cecilia wants to answer that. Can I just ask, you're from Healthy Living NT as a diabetes educator, or Chrissy? I'm just going by the fact you're sitting next to Chrissy.
Yes, Munging's diabetes. Which community was this one in?
East Arnhem.
Oh, it's in East Arnhem. Okay.
I'm happy to talk to some kind of that. I think both Nathan and Ben said it before. Sometimes the things that we think will help are not what people actually think will want for themselves. And that was a completely different conversation earlier today with the Women's Health Network. Most people don't walk around identifying with a particular disease or a particular body part. They walk around having whole lives and have children and caring responsibilities and other things. Like, people don't go, oh, I'm walking around today thinking about my diabetes. Some people might.
Funnily enough.
And so I think sometimes it goes back to that thing about listening. It's about, if that particular thing didn't work at that time, or that structure or that approach, then we need to go and ask some people what they would find more useful, or do they want anything? Because I think the other thing I know I get stuck in is we have to keep imagining a world where services weren't needed, rather than our world being built around how many services do we need to keep building. And part of that is about drawing on community strengths and letting the resources and the power transfer to the way that the communities want to do stuff, and that they want to find those links for themselves as well. And I know some of the work we've done out in East Arnhem with young people is the very last thing they want to do is come to a health service. But they'd very much like the resources to go down together without any health workers for a picnic by the river or the fishing or the whatever, and transferring them the right and the responsibility and the resource to do that is actually part of that real micro change of, I don't know what's best, and it's okay for them to do it. So, and sometimes there's multiple factors, but anyway, the principle for me would be we should ask people what they want and listen to them when they tell us what they want, and then actually give them what they want, rather than tell them that we know better, even though we've asked.
Can I just say
Beautiful
there's
answer.
also diabetes stigma too. So there's a lot of stigma. People are embarrassed, ashamed. I've asked many people, like, or in the waiting rooms, like, or other people ask, do you have diabetes? Because the diabetes educator is here. It's like, no. And then you have a look in the file and they definitely do have diabetes. So there's either diabetes stigma, or there's shame, or there's not understanding about what diabetes, because last time I saw the doctor said I only got a little bit of diabetes. So yeah, and also there is multi-factors too. There could be just, some sorry business that's happened and that's it. All bets are off.
And I think some people are just tired of explaining and repeating the same things being repeated over years and years. There's a number of documents, nobody implements it. It just sits on a nice glossy shelf, just sitting there. There's a number of actions that need to be, it's never been implemented. People are just tired of talking now. When I was at the Indigenous Wellness Conference on Monday and Tuesday, one of the speakers said, consult, 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 30 times. Nothing's happened. I think people are just tired. And you might go to the community and they're saying, there's a yarning service. They're just repeating the same thing. There's a new clinician coming in. The high turnover in the Northern Territory is quite high, or especially in remote communities. We know that. We know that there's, the cost of living is high. Clinicians wanting to be in a more, a suitable lifestyle. We know that. But how do we move upon and move forward? You got to grow your own. Then you grow your own, and then the people who go on move away. Then they get called back. So it's a cycle.
Other questions in the audience? Yes. I can see you're wearing a Me Watch shirt. Thank you for identifying yourself.
Thank you. Yes, I'm Emily from Me Watch. Something that's come up a few times today is the cost of food in remote communities, especially the cost of healthy food. And I know that the calls to subsidise freight were not supported by government in the inquiry into food security and remote stores pricing. Just wondering if there's any plans or what the government is thinking about doing to fix this stubborn problem.
Question for
well, there's changes in the NT as well as Commonwealth. They're probably in neither of the jurisdictions of Cecilia Rule.
So I recall giving an answer not that long ago about how important it is to look beyond your particular domain of responsibility. But I work in the Department of Health. And whilst that question is a really important question, it is actually a question, at least for the Commonwealth, for National Indigenous Australians Agency, I think in particular, particularly in terms of the Northern Territory. And it did play a really crucial role during the pandemic in terms of mobilising the private sector to rethink the way it operated, particularly in terms of some of those freight costs. So it can be shown that it can be done, particularly if you're exercising a convening power and bringing people to have conversations that they don't normally have because you separate the market from government. But there is a big institution called the government as well. And as public servants, we can make recommendations, and parts of the parliament can make recommendations to the government. But if the government says, this is our decision, and it's not my area of responsibility, so I can't speak with great accuracy or knowledge about it, and nor can I say whether there are any plans. But I do know, just as a matter of broader principle, that public servants are always thinking about how can things be better, but they operate in a dynamic relationship with government that has different priorities at different points in time. We see turnover of governments. there's always opportunities for people to kind of re-prosecute positions if there's momentum within an organisation for that as a good idea. So I don't know what the precise plans are. It's a long way of saying no idea. But I can kind of actually go and speak to somebody in that relevant agency to get that information and through whoever, get something back to you. Let's see if I do it. That's the test.
There has been good news recently in the Northern Territory there with legislative change, which again is probably not in Cecilia's area, but it's in the Department of Chief Minister and Cabinet. But yeah, I mean, ALPA in East Arnhem leads the way in terms of implementing the research that was Menzies research led by Julie Brimblecombe. There's 7 sort of main changes for things like pricing and placement, and so in terms of encouraging healthy food within stores, and there's been legislation change in the NT recently that some of those 7 will be enforceable, some will be guidelines, but there's some good changes there. Is my understanding. Millie, want to talk any more to that? Millie probably knows more there than me.
Similar. Sorry. Yeah, I think ALPA were asking a similar question to what Mia Watch has just said. In addition, it's fantastic work that's been done, but regardless, ALPA does already subsidise a lot of fresh fruit and vegetable freight, but it's at big cost and prevents them from providing other things at cheaper cost. So I'm sure any government, like they were at a presentation we went to recently, they were saying that that's something that would really help all of the fantastic work that they're already doing.
Yeah. Other questions? Do we have any online questions? Would Renee like to close? Are we? I'm thinking it's Friday afternoon. I'm sure everyone's happy for finishing before 4 o'clock. Would any of the panel members like to make a closing remark? Nathan is a wonderful orator. Nathan, you'd like to say something?
Yeah, just closing by, just been grateful to be here and listening to great stories and hearing, great initiatives and programs, and I applaud you all, just doing a great job. Hopefully we can keep moving and try to improve the people that are less, in that, but hopefully we can change some things moving forward and into better future, and for all to live in same and equal to one another.
I'll hand over to Renee for the final words.
Really quick. I don't think I've ever spoken so much at anything, so I'm pretty ready to sign off. Just a really big thank you to everyone for all of your time and your contributions. I think we've ended on a really great note this afternoon. Thank you to all of you for being up here today and making all of your contributions. Really, I think some of the main messages of the day have been around the importance of genuine shared decision making. It's really key to breaking down the silos that we need to address the issues that we're all hoping to address to improve outcomes for Aboriginal and Torres Strait Islander people across the north. This is my absolute favourite quote from the work that we've done. It was from a strong woman worker some time ago, and she said, "Because our children, they're our children's future. They're the ones that got to look after our land.